Okay, physical assessment for a neurological exam. We are on page 1346. You use the techniques of inspection, palpation, and percussion. You have to make a decision based upon the acuity of your patient. Do I need to do a focused neurological exam versus an in-depth neurological exam? For instance, it talks about mental status. How in-depth do we want to go? The components of a mental status exam include just the patient's general behavior, which includes the level of consciousness. Are they awake, asleep, comatose? But also cognition. Cognition, are they alert? Are they oriented to time, person, and place? Do they have that higher, more deductive reasoning, such as insight and judgment and problem solving? Obviously, those would not be something that you would check in a focused exam. We'll talk more on the next slide about the levels of consciousness. In a neurological exam, for instance, you might need to check their ability to receive information, their ability to communicate, their ability to speak. There are a lot of new terms that you guys need to understand. For instance, aphasia. Aphasia, there are many different forms of aphasia. One particular type, well, just remember, guys, that your speech centers are in your cerebrum. And so often they are affected when someone has a CVA. One particular type of aphasia is called Broca's, and this is speech production. Possibly you've taken care of an individual who has Broca's aphasia. It means that they understand what you're saying to them, but they are not able to produce clear speech and respond to you. And they are aware of this situation and is extremely frustrating. Often Broca's aphasia is also called expressive aphasia. Another type of aphasia is what we call Wernicke's. And Wernicke's aphasia is different in the sense that the patient has no word recognition. They do not receive what you're telling them and understand it. They can't comprehend it, but yet they'll have or produce clear speech, but it is meaningless. Often, Wernicke's is used interchangeably with receptive aphasia. Other terms that you guys have to be aware of, often they're, I guess, used interchangeably with aphasia, but they are different. For instance, we have the word dysarthria, and this is actually a motor speech disorder, and where there is issues with the muscles that are needed to produce speech. So someone who has dysarthria could be somebody who has Parkinson's, muscular dystrophy, cerebral palsy, ALS, myasthenia gravis, the more chronic type of neurological issues that affect the muscles. Dysphonia is actually when the needed organs to produce speech are affected. So for instance, maybe someone has had their larynx removed, partial laryngectomy, so they have a very coarse voice now because they're missing part of their larynx. Maybe they've had part of their tongue removed for a tongue cancer. So these are the organs that help produce speech, and they are not intact. The Glasgow Coma Scale is something that is used in a focused neurological exam. The best score that an individual can get is a 15. It actually checks best verbal, best motor, and eyes. So best verbal, motor, and eyes. And it is really most useful when trended. So for instance, if someone comes in, let's say, and has a head trauma, or they're a stroke victim, and you do a Glasgow, and their score is 12, which is acceptable. But then you go back an hour later and you do a Glasgow coma scale again, and it's down to an 8. This is alarming. This is showing a decline in their level of consciousness. This would need to be reported immediately. Okay, I wanted to make sure you guys understood the different levels of consciousness, because I often hear these not used correctly. For instance, the other day in clinical, I had a student who actually told me that their patient was obtundant, okay? But yet they were up walking around in the hall. So you can see how this would not be acceptable. And so the levels of consciousness that we need to know is someone who's fully conscious, they're awake, alert, and oriented, and ready to go. Confusion, this is someone who is awake, they're alert, but they have the component of being disoriented, okay? Whether it to be to person and place, to time, just to facts, they do have that disorientation. Then we have someone who's lethargic. This person is alert, they're oriented, but they're sluggish. They're very sleepy. They'll wake up when you come into the room and you call their voice, you get after them, or maybe you actually have to use a little tactile stimuli by shaking them. But they do wake up once you get after them. Someone who's obtundant, very drowsy, minimally responsive. Really have to get after them to get them awake. You have to shake them, or maybe even use some type of deeper stimuli to get them awake. They can only stay awake for a few minutes and they're quickly back to sleep. It's difficult to get to this individual to be able to follow commands. And then we have someone who's stuporous. They may be only moan and groan to their name. You say their name, you shake them, and what you get out of them is a moan. If they wake up, it's only for a brief period of time, and you cannot get them to follow command. And then comatose. Comatose is they do not respond to verbal stimuli. They will not speak. They will not follow commands. And what we might get out of them is either decerebrate or decorticate posturing, which we're going to go over in a little bit. When we're talking about stimuli, you guys have to realize that there are different types of stimuli, okay? So there's verbal. So verbal just means that you're talking to them. You wake up, you walk in, you say, "Good morning, Mrs. Smith." They open their eyes. That's verbal stimuli, okay? You also have to realize there's tactile stimuli. Tactile stimuli would be you walk in, you say their name, Mrs. Smith, no response. So what do? You go over and you gently, shake their shoulder. They wake up. That's tactile stimuli. But then you have to understand that there's what we call deep stimuli. You walk in, Mrs. Smith, no response. You go over and shake her, no response. Mrs. Smith won't wake up. And so you use what we call deep stimuli. And a lot of times deep stimuli is used interchangeably with what we call painful stimuli. Painful stimuli would be, for instance, that we would take an object and press it on their nail bed to see what type of response that do we get from them. Do they have a purposeful response where they withdraw or try and get away from the painful stimuli, or do they not react to it at all? Other forms of painful stimuli that you could see but are not acceptable are sternal rubbing, where you actually take the knuckles on one of your hands and you actually rub the patient's sternum, causing friction on the skin and a possible skin breakdown. And then there are times when you'll actually see healthcare practitioners pinch nipples and see what type of response they get. The acceptable form of painful stimuli is to take an object such as a pen or a pencil and press it against the nail beds firmly and see what type of response you get.